Hello friends, welcome back to lobes. Normally, the fetal vessels are enclosed within the umbilical cord and cushioned by the Wharton jelly and it safely reaches the placenta. In some conditions, the fetal vessels are leaves the umbilical cord early and pass through the membrane and it reaches the placenta. If that fetal vessels are cross the internal os, that is called Vasa Previa. By the end of this video, you will have a clear understanding of introduction, types, pathophysiology, risk factors, clinical features, diagnosis and management of Vasa Previa. Let's enter into the topic. What is Vasa Previa? Vasa means fetal blood vessel. Previa means before or obstructing the way. So the vessel in the way before the baby. So the vessel obstructing the pathway. Vasa previa is the rare but serious obstetric condition where fetal blood vessels run through the membrane. Which membrane? Amnion and chorion. Amnion is the inner layer that surrounds the fetus and it contains amniotic fluid. Chorion is the outer layer. It is contact with uterine wall and the placenta. And this fetal vessel is unprotected by the umbilical cord or the placenta and it crosses or very close to the internal os. So the unprotected fetal vessel run through the membrane and cross the internal os. That is Vasa previa. Types of Vasa previa. Based on the origin and the path of unprotected fetal vessel, the Vasa previa is classified into two main types. Type 1 Vasa previa is caused by the Velamentous cord insertion. Type 2 Vasa previa is two-lobed, which means bilobed placenta or accessory placenta. Type 3 Vasa previa, it is the rare and unclassified type. It is less common and it is associated with low-lying placenta or abnormal placenta development. Type 1 Vasa previa, you can remember it like type 1 insertion abnormality. It is caused by the Velamentous cord insertion. The fetal blood vessel travel from the cord to placenta within the membrane without protection from the Wharton's jelly. That is Velamentous cord insertion. If that unprotected fetal vessel cross the internal os, that is called Vasa previa associated with Velamentous cord insertion. This is type 1. Type 2 Vasa previa. You can remember it like type 2 two lobes. Two lobes means bilobed placenta. So it is caused by the suction site or bilobed placenta. So the fetal vessel run between the two lobes of placenta. So the cross over the internal os, that is called Vasa previa. So this is type 2 Vasa previa. Type 3 Vasa previa, it is a rare and unclassified type. It is less commonly mentioned and it is proposed as a classification for the case that does not fit in the type 1 and type 2. What is type 1? That is insertion abnormality. The fetal vessel early leaves the umbilical cord and reaches the placenta and the unprotected fetal vessel cross the internal os. That is type 1. Type 2 means two-lobed placenta. So the fetal vessel run between the two lobes and passes through the membrane and crosses the internal os. That is type 2. The case that does not fit in the insertion abnormality and bilobed placenta or type 3. So the type 3 is associated with low-lying placenta or abnormal placental development. So the abnormal branching of fetal vessel exit and re-enter the placenta with normal umbilical cord. So the fetal vessel cross the internal os. That is Vasa previa type 3. Now the risk factors of Vasa previa, that is Velamentous cord insertion, succensurate lobe or bilobed placenta, placenta previa, multiple gestation, in vitro fertilization, and previous uterine surgery or procedure. In multiple gestation, the monochromatic twin shares the placental structure, so it may cause Vasa previa. In vitro fertilization pregnancy, the abnormal placentation may occur, or in the case of previous uterine surgery or procedure, the alteration of implantation site, abnormal placentation development may occur. These are the risk factors of Vasa previa. Next, pathophysiology, the abnormal placental anatomy, which means Velamentous cord insertion or succensurate lobe that causes the fetal vessel run through the membrane instead of being protected inside the umbilical cord. The unprotected fetal vessel run through the membrane, so it can tear anytime after membrane rupture. The vessels are fetal vessels, right? Not maternal. So it causes massive fetal hemorrhage. So the loss of blood can cause hypovolemia, hypoxia, and even death also. Why is it dangerous? The vessels are the part of fetal circulation, not maternal. These vessels are vulnerable to rupture, especially when the membrane rupture during labor. If the vessels are ruptured, it can lead to rapid fetal blood loss and fetal death if not managed immediately. Now the clinical consequence of Vasa Previa. So the painless vaginal bleeding in the second or third trimester, often at the membrane rupture, fetal distress or bradycardia due to blood loss, abnormal fetal heart rate or absence of maternal signs of shock. These are the clinical consequences. Antepartum diagnosis. The transvaginal color Doppler ultrasound, that is gold standard for the Vasa Previa. It shows the fetal vessel crossing the internal os. The color Doppler helps to confirm that these vessels are fetal. How? The pulsatile flow synchronous with fetal heart rate. The fetal heart rate and the blood flow in the fetal vessels are sync. So that is pulsatile flow synchronous with fetal heart rate. Transabdominal ultrasound may initially suggest Vasa Previa, that is less sensitive. The transvaginal scan is usually done to confirm. Intrapartum diagnosis usually discovered after rupture of membrane. The classical triad that helps to diagnose the Vasa Previa. The painless vaginal bleeding, fetal distress, and ruptured membrane. These are the classical triad for Vasa Previa. And the APD test, it is rarely used nowadays. It is used to differentiate the fetal blood and the maternal blood. Management of Vasa Previa in antenatal period. Confirm the diagnosis by 20 to 24 weeks with color Doppler ultrasound. Hospitalization at 30 to 32 weeks for close monitoring. Corticosteroid administration. Administer the betamethasone at 28 to 32 weeks to promote the lung maturity of the fetus. Management at delivery. Elective cesarean section at 34 to 36 weeks before labor or membrane rupture. Avoid digital vaginal examination or artificial rupture of membrane. Emergency management. If the Vasa Previa is undiagnosed and presented with vaginal bleeding after membrane rupture, fetal bradycardia or fetal distress, immediate emergency C-section is indicated to prevent fetal death and resuscitate the newborn if the fetal hemorrhages occur. And the newborn may need transfusion also. Finally, we are coming to the happiest slide. Overview of Vasa Previa. Vasa Previa is the serious obstetric condition where the unprotected fetal vessel run through the membrane and cross the internal os. That is Vasa Previa. It is classified into two main types. Type 1 is caused by the Velamentous cord insertion. Type 2 is caused by the accessory lobe or bilobed placenta. And type 3 it is rare and unclassified type. It is due to low-lying placenta or abnormal placenta development. Pathophysiology, the abnormal placental anatomy that causes unprotected fetal vessel run through the membrane. So the rupture of membrane that causes massive fetal hemorrhage. So that can lead to fetal hypoxia, hypovolemia and death. Clinical features are painless vaginal bleeding after membrane rupture, fetal distress, absence of maternal signs of shock. Antepartum diagnosis, the transvaginal color Doppler ultrasound, that is gold standard to confirm the Vasa Previa. Intrapartum diagnosis with the classical triad and APT test. Management, confirm diagnosis by the 20 to 24 weeks with color Doppler. Hospitalization for close monitoring. Administration of corticosteroid for fetal lung maturity. And the elective cesarean section by the week of 34 to 36 weeks before the labor or membrane rupture. Avoid digital vaginal examination and the artificial rupture of membrane. If it is emergency, immediate emergency C-section is indicated to prevent fetal death and resuscitate the newborn if fetal hemorrhage occurs. Thanks for watching. If you have any suggestion, give your valuable comments in the comment box. Thank you.